Week 4 is on chromosomal and genomic basis of disease. The learning objectives are to describe human disorders resulting from chromosome abnormalities of autosomes and to describe human disorders resulting from abnormalities of the sex chromosomes. Looking at chromosomes and miscarriage, atypical chromosomes account for at least 50% of miscarriages or spontaneous abortions. Only 0.65% of newborns actually do have atypical chromosomes. Most embryos and fetuses with atypical chromosomes stop developing before birth. Looking at autosomal chromosomal anomalies first, Down syndrome, most common chromosomal anomaly with an incidence of 1 in every 850 births, was first described by Dr. John L. H. Down, who published an article in 1866. At the time that he published the article, the cause remained unknown. In 1959, Lejeune showed that individuals with Down syndrome had an extra chromosome, a number 21. Please go to the article about Down syndrome, which gives you a good historical perspective of Dr. Down and how people felt about individuals with Down syndrome at that time. And it will also discuss how Dr. Down was considered to be a racist because of the way what he had named the syndrome, which was Mongolism in the very beginning. But it's a very interesting article. Here are some typical pictures of individuals who have Down syndrome. If we look at what's referred to as the full trisomy 21, and you can see the karyotype on this picture here with the circled, you have the 3 number 21s. 94% approximately of all individuals who are born with Down syndrome have the trisomy 21. And this is because of non-disjunction during meiosis. We look at this as being caused primarily by advanced maternal age. We're now looking at paternal age as being a factor in trisomic cases, a mother being over 35 and a father being over 50. Only 20% to 25% actually survive to birth. Again, we're looking at the same graph that we saw last week, showing that what happens with maternal age with the increase in individuals that have Down syndrome due to non-disjunction. As we hit 30, we start to go up. 35 is considered to be the cutoff where we feel that over 35 needs to be offered the prenatal diagnosis. Aneuploidy, we talked about last week, the most common mutation in our species. It leads to the production of abnormal gamete that has 2 copies or no copies of the chromosome involved in the non-disjunction event, either in meiotic division number 1 or 2. The recurrence risk of trisomy 21, as well as any other autosomal trisomy disorder after the birth of one affected child, is about 1% overall. It's about 1.4% for mothers younger than 30 years and the same as the age-related risk for older mothers. The reason is currently unknown for this. About 4% of all cases have a translocation, a Robertsonian translocation, half of which are inherited. 14, 21, and 21, 22 translocations occur with nearly equal frequency. However, the translocations between chromosomes 13 or 15 or 21 may also occur. The odds of having another child with Down syndrome is increased when one parent carries a translocation, especially the mother. Theoretically, it is about 1/3. If we look at the 21q translocation, this is seen in a few percent of Down syndrome patients. It's thought to originate as an isochromosome. It's important to evaluate if a parent is a carrier, since potential progeny would have Down syndrome or monosomy 21, which is rarely viable. Mosaic carriers are at an increased risk for recurrence, and prenatal diagnosis should be considered in a subsequent pregnancy. This is a karyotype of a child who was born with a 1421 translocation. Please note this child has 46 chromosomes. The genetic material of 47, but has only 46 chromosomes. Take a look at the number 14. The number 14 has a 21 chromosome on top of it. If you look at a parent that has a balanced translocation, if the parent has this balanced translocation, he or she will have 45 chromosomes and the child will have 46 chromosomes. The parent has the genetic material of 46 chromosomes. The child has the genetic material of 47 chromosomes. The child has an unbalanced translocation. A mosaic. Mosaicism is defined as the presence of two or more cell lines in an individual or body. Tissues that, although genetically different, have evolved from the same zygote. Somatic and germline mosaicism exists. About 2% of all cases are mosaic with a normal cell line in addition to the trisomic cells. 47, for example, plus 21/46. The degree of problems that a child has is going to be dependent upon the number of cells that are affected by the trisomy. A partial trisomy 21 is very rare, and it's where you only have a part of the long arm of the chromosome 21 that is in triplicate. For prenatal screening and testing, the prenatal screening NIPS utilizes cell-free fetal DNA in maternal plasma. And genetic testing, as we talked about it last week, you have the direct method where you would do the amniocentesis or chorionic villus sampling. The diagnosis may be made at birth or later for Down syndrome by the presence of a combination of some of the following findings, referred to as a syndrome when put together. Hypotonia. The babies are very floppy. Mental retardation with an IQ between 20 and 60. Short stature. Brachiocephalic skull, flattened occiput and facial profile, upward slanted eyes. These babies may also show brushfield spots, a speckled iris when you shine a light into their eyes, a small nose with a depressed bridge, an open mouth with a protruding tongue. Their jaws are very small. Their tongues are not larger. Small square ears with an overfolded upper helix. Their hands are short and broad. They have what's called a simian crease, and they have the incurving of the fifth finger, which is called clinodactylia. Their feet have a wide gap, referred to as a saddle gap or turkey toes, between the first and second toes. They have a poor Moreau reflex or startle reflex, and a Moreau reflex is how a baby reacts with a sudden loud noise. When this occurs, they stretch out their arms and their feet. And the current life expectancy for a person born with Down syndrome is 55 years. Here we can see the brachiocephalia, the short skull front to back, the excess at the back of the nape of the neck of the skin, the knuckle, the hypoplastic or underdeveloped midface, upper slanting or palpebral fissures, eyelids, small ears with an overfolded helix. The child in this picture is showing the flat appearing face, the small head, the small mouth and jaw, which causes the tongue to stick out and to appear overly large, upward slanting eyes, rounded cheeks, and you cannot see that from here, but he is weak and floppy, and his muscles have what is called hypotonia. Here you see that gap between the first and second toe. The tongue, they're showing that when you stick it out, it appears to be quite large. Simian crease in the palm of the hand straight across. And then you see the hypotonia and decreased muscle tone in the baby, as well as the epicanthal folds. Some of the other findings in babies that are born with Down syndrome is that they have congenital heart defects. This is found in about 30 to 40% of the babies. We also find duodenotatresia and tracheoesophageal fistulas, which is more common in Down syndrome than in any other disorders. There's also a lower fertility rate, which is found in both males and females, but especially the males. Children born with Down syndrome are at increased risk for thyroid diseases, for hearing and vision problems, for Alzheimer's disease, and for leukemia. It is very important to remember that there are three ways that a child may present himself or herself as having Down syndrome. It may be from trisomy 21, 94% of the cases are from this due to non-disjunction. It may be due to translocation, approximately 4%, or the child may exhibit mosaicism. Trisomy 18, which is also known as Edwards syndrome, was first described in 1960. It occurs approximately 1 in every 3,500 births. It is caused by non-disjunction in the meiotic division number 1. There is a 3-to-1 preponderance of females over males, and the infants have many congenital defects. This is a karyotype showing you some G banding of the chromosomes with the number 18 shown in trisomy. If we look at a child that's born with trisomy 18 syndrome, we would note that the baby would have a low birth weight, marked failure to thrive. There's very little subcutaneous fat. Only 10% survive the first year of life. They have microcephalia and micrognathia. They have a clenched hands with an index finger overlapping the third finger and the fifth finger overlapping the fourth, sometimes seen in the feet too. There's an arch pattern on 6 or more fingers by looking at dermatoglyphics, and they have hypoplastic fingernails. Babies born with trisomy 18 have rocker bottom feet quite often. I will show you a picture of that in just a moment. Many of them have congenital heart disease, especially in the forms of ventricular septal defects, VSDs, or patent ductus arteriosus, PDA. They have low-set malformed ears, which are referred to as elfin ears. Here is a baby with the characteristic hands. This baby is a little plumper than some of the others that are born with this disease. You cannot see the rocker bottom feet at this point. And with the bulbous nose, we see here's 3 children that have the trisomy 18. Again, the hands. You saw this slide before, but I wanted to show you this because it was very good to show you how they hold. This is a slide showing you the rocker bottom feet, which often remind you of a bentwood rocker. Trisomy 13, known as Pateau syndrome, very rare, and generally the children do not survive 6 months. There are serious mental and physical disabilities associated with this disease. And one of the distinctive features is eye fusion. In Pateau syndrome, it occurs 1 in 5,000 births. It's severe, and 80 to 85% of the babies die by the first year of life. It is usually caused by non-disjunction due to advanced age, but there are some translocations that do occur. Here is a karyotype showing you trisomy 13. One of the things to notice here is that the chromosome 13 is bigger than chromosome number 18 and number 21. There are a lot more genes on here, so that when you have a trisomy, would have a greater effect than 18 or 21. Looking at the syndrome, you would see babies that have a slanting forehead and a large bulbous nose, low-set abnormal external ears. They have polydactylia, but they basically, quite often, they look like skin tags. A simian crease, again, we see with this syndrome. Congenital heart defect, about 80%. Abnormal genitalia with the males having cryptorchidism and a bifid scrotum, and the females have a bicornate uterus. The criteria for diagnosis include a maldevelopment of the forebrain associated with an underdevelopment of the olfactory and optic nerves, cranial nerves 1 and 2. There is severe mental retardation, which is associated with seizures and apneic spells in infancy. Microphthalmia and/or iris colobomata can occur, and we see sometimes that babies are born that do not have any eyes at all. Or in some cases, they may just have the fusion of their nose and their eye and have only one structure in the middle of their face. We also see cleft lip and cleft palate associated with trisomy 13. Remember that cleft lip and cleft palate can occur in various syndromes, but it can also occur either just as a cleft lip, just as a cleft palate, or both. Looking at this picture here, there's a comparison between trisomy 18 and trisomy 13. So you can see the findings of the two up against each other here. This little baby here who has the polydactyly, if you look closely at the fingers, and has no eyes actually, if you were to try to open up the fissures, there are no eyes there. And then the baby has a very deep cleft palate. So the features that you can recognize when a baby's born who has trisomy 13, small head size, either small or no eyes. 60% of the children have a cleft lip, cleft palate, extra toes or fingers, and 80% of the children have a heart defect. Looking at chromosome deletions, the loss of a segment of DNA from a chromosome is a chromosome deletion. First detected in 1963 by Lejeune when he visited children who had mental retardation and multiple congenital anomalies. They had a condition called cri de chat syndrome, because the cry of the cat, because when they cried when they were young, they sounded like a cat. They were found to have a deletion in the short arm, the P arm, of chromosome number 5. How much of a deletion that occurs with the cri de chat can vary, but the greater the deletion, the more affected the individual. And here you can see a pedigree with circled the chromosome number 5. You can see that it looks shorter than its pair. Here's another picture showing you the P arm and the Q arm and two chromosomes put up next to each other, so you can see the deletion, and then you can also notice it in the ideogram next to it. Cri de chat occurs because most cases are sporadic. 10 to 15% are the offspring of translocation carriers. 1 in 15,000 live births is the incidence. The babies have microcephaly, low-set ears, hypertelorism, wide-spaced eyes, epicanthal folds, poor weight gain, feeding problems, developmental delay, and speech and behavioral problems. Here is a picture showing you 3 girls who were born, and I did not have a picture of a male, but there were 3 girls who have cri de chat. In order to identify deletions, large deletions can be identified by karyotyping G-banded chromosomes. The smaller deletions, you would have to look at microarrays. In looking at genomic imprinting and clinical cytogenetics, several hundred genes in the human genome show imprinting effects. Only one allele, either maternal or paternal, is expressed in the relevant tissue. The effect on the clinical phenotype depends upon which parent the mutational event occurred in, either maternal or paternal. Imprinting, as you know, is when an individual normally has one active copy of an imprinted gene, and improper imprinting can result in an individual having 2 active copies or 2 inactive copies. This can lead to severe developmental abnormalities, cancer, and other problems. If we look at imprinting in human disease, there are 2 distinct syndromes that result from a small deletion in chromosome 15. If the deletion is inherited from the father, then the children would have Prader-Willi syndrome. If the deletion is inherited from the mother, the children would have Angelman syndrome. Here we have a slide showing you Prader-Willi syndrome and Angelman syndrome, and you can see the chromosome number 15. Looking at Prader-Willi, the symptoms include learning difficulties, short stature, and compulsive eating. Individuals are missing gene activity that normally comes from the dad. This happens when the dad's copy is missing or when there are 2 maternal copies. For Angelman syndrome, the symptoms include learning difficulties, speech problems, seizures, jerky movements, and an unusually happy disposition. Individuals are missing gene activity that normally comes from the mom. This happens when mom's copy is defective or missing, or when there are two paternal copies. Here we have X and Y chromosomes, and you can see that there's a big difference in size between the X and the Y. Sex chromosomal anomalies. Females are homogametic. Males are heterogametic. They produce both X and Y gametes, hence are hemizygous for X-linked genes. There's few genes on the Y chromosome. Many genes are on the X chromosome. If we look at the X chromosome, one of the two X chromosomes condenses during interphase to form an X chromatin mass called a Barr body in a female. Barr and Beetram in 1949 discovered this. It is located on the inner surface of the nuclear membrane and measures about 1 micron in diameter. Barr bodies are present in only about 50% of epithelial cells, and they can be seen if one does a buccal smear. Normal males are X chromatin negative. Since normal males only have one X and a Y, they do not have a Barr body because they cannot inactivate an extra one. Normal females are X chromatin positive. If you were looking at someone that had Klinefelter syndrome and was 47XXY, that individual would show, just like a woman, they would show Barr bodies. There is always one more chromosome than the number of Barr bodies. Here is a picture, a slide showing you the Barr body. You can see it delineated there by the lowercase b. Buccal smear preparations may also be used to identify the Y chromosome. The distal half of the long arm of the Y chromosome exhibits bright fluorescence when appropriately stained and examined under ultraviolet light. It bears a 1-to-1 relationship to the number of Y chromosomes. Since it is the short arm, the non-fluorescent arm of the chromosome which determines maleness, absence of fluorescence does not necessarily indicate absence of all Y-determining genes. It's generally assumed that the Y chromosome must be present for testes to be formed. There are one or more genes concerned with stature that are found on the Y chromosome. 45X, Turner syndrome. The phenotype was discovered by Turner in 1938, and the genotype was found by Ford in 1959. The incidence is 1 out of 2,500 newborn females, and 15% of spontaneous miscarriages are where the miscarriage fetus had Turner syndrome. 1 out of 20 Turner syndrome conceptions result in a live birth. Clinical findings: female phenotype, webbing of the neck in 50%, edema on the dorsum, hands and feet. One of the things to look for when you're in the newborn nursery are puffy hands and feet. They also have a low hairline. Some of the other characteristics of individuals with Turner syndrome are that they have pigmented nevi. Many have the congenital heart defect of a coarctation of the aorta. They have primary amenorrhea. They're infertile and actually have what are like streak-like gonads. And the mechanism by which a child normally gets Turner syndrome is by non-disjunction. This is a karyotype from a woman with Turner syndrome showing one normal X chromosome and an isochromosome for the long arm of the X. This slide is showing you some pictures of some girls who have Turner syndrome. You can see the edema that's present in the baby in the back of the neck here. You can see the low hairline. There is also associated with Turner syndrome a elbow defect where the arms cannot be bent very easily. Here you see a karyotype of an individual that has Turner syndrome, 45XO. And this slide shows you some of the basic characteristics of an individual that has Turner syndrome. Fold of the skin and the webbing of the neck, constriction of the aorta, poor breast development, elbow deformity, rudimentary ovaries, streak gonads, um, amenorrhea, brown spots called nevi, small fingernails, shortened metacarpal. Number 4, widely spaced nipples, a shield-shaped thorax, and short stature. Triple X syndrome occurs 1 in 1,000 female births. There's a few effects on the phenotype, and these include tallness, menstrual irregularities, and a slight impact on intelligence. X inactivation of two X chromosomes occurs, and the cells have two bar bodies. It may compensate for the presence of an extra X. XXY, Klinefelter syndrome, has a male phenotype. It was discovered by Klinefelter in 1942. The incidence is in 1 in 1,000 newborn males, and it is caused by non-disjunction. If you look at the clinical findings associated with Klinefelter syndrome, they have a normal appearance until puberty. Gynecomastia occurs in 25%. They have a euconoid appearance, which is long limbs, large hands and feet. They have rudimentary testes and prostate, and it is a common cause of infertility. If we look at the clinical features of a Klinefelter's XXY individual, we would see that they have poor beard growth, narrow shoulders, wide hips, small testicular size, long legs, female type pubic hair pattern, breast development, tendency to grow fewer chest hairs, and frontal baldness is absent. If you were to look from at the posterior view of an individual with Klinefelter syndrome, they would actually look like a female because they have female deposition of fat. Here you have a karyotype of an individual that has Klinefelter syndrome, 47XXY. If we look at an individual who is XXYY, this arises due to an unusual oocyte in sperm. It's associated with more severe behavioral problems than Klinefelter syndrome. They have AAD, obsessive compulsive disorder, and learning disabilities. Individuals are infertile. They are treated with testosterone. If you look at Jacob syndrome, XYY, this occurs 1 in 1,000 male births. 96% are phenotypically normal. They have modest phenotypes, great height, acne, speech and reading disabilities. Studies suggest an increase in aggressive behaviors. However, these are not supported, and it led to a lot of misinformation in the 1960s and early 1970s when Richard Speck, who was a mass murderer, was accused of having Jacob syndrome or XYY syndrome, and it was shown later that he did not. If you look at uniparental disomy, UPD, this happens if non-disjunction occurs in both a sperm and an oocyte, and a pair of chromosomes or their parts can come solely from one parent rather than one from each. This would mean that you'd inherit two chromosomes or chromosome segments from one parent. This process is called uniparental disomy or UPD. UPD can also arise from a trisomic embryo in which some cells lose the extra chromosome, leaving two homologs from one parent. Since UPD requires the simultaneous occurrence of two rare events, either non-disjunction of the same chromosome in the sperm and oocyte or trisomy, followed by chromosomal loss, it is indeed rare. Many cases are probably never seen because bringing together identical homologs inherited from one parent could give the fertilized ovum homozygous lethal alleles, and development would halt. Other cases of UPD may go undetected if they cause known recessive conditions and both parents are assumed to be carriers, when only one actually had contributed the genes. This was how UPD was discovered, and we will come back to look at it later. But this is the end of the Unit 4 lecture. I would like you to do the exercises that I have assigned, as well as you will be taking a test, and this test will be on all the material that you had in weeks 1 through 4.